Good afternoon, and welcome to Navigating the Employments of mHealth from the Hospital to Home. I'm Don Jones, Vice President of Global Strategy and Market Development for Qualcomm Life, and I've got 5 colleagues here with me, all with experience on actual deployments. What I've asked each of our presenters to do is to give a short, we'll call it 5 to 7 minute overall presentation about what they're actually doing. We're then going to do a little bit of interaction between the group, and then we'll open up for questions. So, we'll have some time for you to query the folks on their learning curves. Thank you very much for closing the back door. So, the first company we're going to talk to is Preventus. Very, very interesting company in the body-worn sensor arena, and I look forward to hearing John talk to us about what Preventus is up to. So hopefully we can get the slides coming up.
Good afternoon, and thank you for taking the time this afternoon to enjoy this panel. My name is John Otterstetter, CEO of Preventus. As Don said, the activity here is to discuss hospital to home. We started the company about 5 years ago and quickly learned that the only thing that really mattered is how a physician looks at technology and uses the technology, and the patient adopts and or uses the technology. I tell my team often that if the technology is not prescribed and it's not used or able to be used, none of this matters. So these 3 very, very key components are essential to changing the engagement between a physician and this patient or her patient. When we looked at the problem, we tried to dissect that problem into basically 4 components. The first of which is patient education. And if you think about patient education and the patient attending time with his or her physician, it's critical in the improvement of the outcome, and it's critical in the improvement of the economic value. And you could talk about drug adherence, you can talk about compliance to a care plan, etc. We chose to work with a partner and integrate live mobile education. So libraries of education around any basic topic in healthcare. And the capabilities that we now have with the iPad, with mobile connectivity, makes it a wonderful addition to help drive that patient engagement and the outcomes to even new levels. The treatment or discharge equally is critical. How many times has an individual been to a physician and you have maybe that 5 or 6 minutes at the tail end and they're telling you an enormous amount of information and you go home and go, well, I think I got about 5% of that. Now what do I do? Well, you don't get the luxury of calling the physician back. So the thought here is when you are discharged, the care plan goes with you. With the ubiquity of the mobile devices that we have today, iPads, iPhones, even the web presence, it's a wonderful way to deliver a connectivity back to that care plan. And the other thing we've learned working with a very large clinic in Minnesota is that the care plan, there's a component of that care plan called remote monitoring. We've worked with this institution and created a body sensor that does a full ECG, has momentum, movement, position, and number of future activities. And the linkage of those physiological inputs back to the care plan removes some of the subjectivity from the care plan. We've all gone to the doctor, and the doctor says you should have 1 less red wine, or maybe you should exercise a little more, you should lose 3 pounds or 5 pounds or 15 pounds. Do we really follow that? So the thought here is ultimately, especially in the chronic disease cases like CHF, atrial fib, etc., can we get to a more passive input with an objective? And this body sensor was recently approved by the FDA. We're very excited about that. So it goes from pre-treatment, treatment, and then, of course, post-procedure and recovery. And a couple of the trials we've most recently completed, one very interesting trial was a 30-patient IRB-approved post-cardiac surgery. The intent was, of course, to reduce ICU time, but the secondary intent was really to encourage the patient recovery. Get that patient back into his or her home or comfort setting where the doctor can still have monitoring capabilities tied back into the care plan that he or she's prescribed to that patient. It drives a wonderful cycle. So we think these are the four fundamentals: care plan management, patient education, remote monitoring, and relationship management. Now quickly, the quants and the data enthusiasts think about all of the data that is amassed and what can be extracted from insights, what can be detected and predicted in the pattern of individuals in a given demographic, maybe the same disease state, et cetera. We have that as a latent capability. I'm not spending quite a bit of time there yet. So this brings it together. We don't have time to click on some of these examples with YouTube videos behind there, multimedia to show testimonials of patients that have either used our remote monitoring system, named the Body Guardian. We've built other applications that basically follow the fundamentals of this diagram, which is the care plan, links to the education, links to remote monitoring, and the relationship back to the physician. The early indicators on the trials, the outcomes are significant. This morning there was a panel that talked about 75% reduction, some of the readmission rates. These are some numbers that I believe, as a supplier to the industry, using mobile connectivity, tied to an institution that has clinical credibility, proven by the physicians, adopted by physicians, prescribed by physicians, and usable by patients. It's a wonderful addition. With that, I'll hand it over to Andy. Or back to Don.
Next, I'm going to introduce another one of our colleagues here, Andy Schoonover, who comes to us from VRI. And Andy's got an interesting story about how he got into the business, so I hope he shares a little bit of how he went through an entrepreneurial path to get into the remote monitoring space. Andy?
Thanks, Don. I will share a little bit of background because I think it gives you some good context for what we're up to. I want to rewind back to 2006. I was a second-year MBA student, and my roommate and I were having that conversation that I think a lot of second-year MBAs have, and it's what do you want to do with the rest of your life? In the 2006, things were good. The Googles were taking off. We actually rented our house to these guys between our first year and second year of business school. And if you ever seen The Social Network, that was my house that they rented. So things were going good out in Silicon Valley. Things were good in the private equity space, but we wanted to do something a little bit different. So we raised a little bit of money, went out searching for a company to buy. We're both sons of nurses, so we wanted to get into the healthcare space. So found this little company in, of all places, Dayton, Ohio. So you can probably imagine how excited we were to move from Palo Alto to Dayton, Ohio. I actually love Ohio, but it was a bit of a shell shock as we moved out there. But we found this really cool company called VRI. Everybody wonders what VRI stands for, but 20 years ago it was Valued Relationships, Inc., and people were calling in thinking it was a dating service. So we quickly changed the name to VRI. Company had some really neat capabilities, some really great relationships. Had relationships with discharge planners across the country. Had this IT monitoring infrastructure that was really interesting. And so what we decided to do is we were doing medical alert systems at the time. So I've fallen and I can't get up. We do monitoring of those types of systems. We do medication adherence, so we have a device that organizes and reminds you to take your medications. If you don't, then it will ping my call center, who will call you back and say, hey, Mrs. Smith, it's time to take your meds. But we wanted to do something different. We wanted to do something more. So we went to about 20 or 25 chief medical officers, chief financial officers at health plans and hospitals across the country. and it basically asked them, what else can we do? And they all came back and they said, this telehealth thing is interesting. And when I said, okay, well, what's the market? How much are you using it? Are you using a lot of it, not a lot of it? And they said, well, we're playing with it, toying with it, but it's really hard. They all came back with very similar issues with telehealth, remotely monitoring vital signs out of the home. If you go out on the exhibit hall floor, you can probably choose a dozen different providers of telehealth hubs and equipment, and so these health plans and hospitals have come back to us and say, I don't know which one to choose. And then once I choose one, they want to drop it off at my front door. Well, they're expensive, as most of us know for the most part. And then they drop them off at my front door and say, good luck. And the hospitals and health plans were saying, well, what do I do with this stuff? How do I get it into the home? Because as we know, the typical demographic that we're working with on some of these readmission projects are, typically elderly folks, don't typically like technology. So, how do you get it in the home and get them comfortable with the technology? Once you get it in the home, how do you monitor that information, or what do you do with the data? So Aetna and Intel did a pilot, I think it was 2 or 3 years ago, where they had 187 members over a 6-month period, and they got 27,000 alerts from these devices. So what does a health plan or a hospital do with all of this data, and how do they get clinicians involved when there is an alert that they really need to pay attention to? Technical support, adherence, how do you get people to adhere to these things? As we all know, if you have heart failure and you don't step on that scale every day, it's pretty much useless to put a scale in your home. And then once you're done, given this is so expensive, how do you get it back out? How do you get it refurbished according to FDA standards and get it into that next home? So what we decided to do is build a portfolio of services around some of these issues. So let me give you just a quick case study, and we're actually doing this with Qualcomm, VRI, and Tri-City Medical Center. Just announced that we're going to do a readmission project for them. Tri-City is in the San Diego area. So quick kind of case study on this. Mrs. Smith has heart failure. She's been admitted for heart failure. We get a call, a fax, an email, an electronic connection with the hospital who tells us that Mrs. Smith is getting out of the hospital today. We will then send an installer to install this equipment within 48 hours in Mrs. Smith's home. We'll spend about 30 or 45 minutes with her. We'll make sure she's comfortable with it. We'll make sure all the peripherals are set up, that the data is getting into our system. And then once we have that set up, we have a call center of nurses who are watching that information. If Mrs. Smith gains 3 pounds, for example, we can call her. We'll ask her some additional questions, 5 or 6 questions, not a long time. But then we'll couple those questions with the historical data and come up with a stratification. The typical red, yellow, green stratification. If it's a red, we'll call their doctor and say, hey, doc, we need to get involved with Mrs. Smith. We actually don't typically talk to the doctor, but we'll talk to the doctor's nurse or MA or someone at the doctor's office. And then that doctor will then get involved and keep Mrs. Smith from going to the hospital. After she's done with it, we will pick it up and refurb it and put it into the next home. A couple things that have tripped up these telehealth programs in the past. Adherence. So we will call Mrs. Smith if we don't get readings. So we have a timer in our system that if we don't get a reading by, say, 9 a.m., we'll call her and say, hey, Mrs. Smith, it's time to take your readings. So and we've gotten really good adherence rates, and I'll show you in a minute. This is just one plan that we worked with just to give you an idea of some of the things that we've done on the monitoring side to help this plan. I'm going back to this Aetna and Intel study where they just got inundated with data. They were having the case managers at the health plan retrieve the data and then react to the data. And as you can probably imagine, those case managers said, I've got a day job. I can't deal with all of this data. You're basically getting an alert every other day from these members. How do I deal with this? So this is a plan that has about 1,600 members that are being monitored by us. It was a 4-month evaluation period. We touched those 1,600 members almost 66,000 times. And this is the graph that shows you how many times per type. So we called about 30,000 times to remind them to take their readings. And of the readings we got, alerts were about 2%. The red alerts were about 2%, meaning that per our algorithms, 2% of the actual alerts that came in are actionable, meaning that we need to get a clinician engaged. So we took that huge set of alerts, narrowed it down, and said, clinicians, you need to get involved in these. Don't worry about the rest of them. We'll watch them. We'll make sure that those members, those patients are going to be okay. I want you to focus in on the 2%. One of the problems we've seen in the past is, if you call the doc is going to say, come on, you just called me yesterday about the same patient. And they talk to the patient, and the patient, ran up the stairs or walked up the stairs before they took their blood pressure, and so their heart rate was high. And that would indicate that something is going on when all they did was walked up the stairs. In our case, what we would do is say, hey, Mrs. Smith, take a chill for the next 30 minutes, redo it, and then we will see if that sets an alert. So you have a resting heart rate. So we get rid of most of those types of alerts. A lot of these are tech support issues also. I don't care what type of device you have. These Bluetooth devices get disconnected and things happen, and we can tech support that. Case managers, doctors, clinicians don't want to deal with any of that stuff. So, we did a really good job in this plan. Also did a good job. Whoops, I'm missing a slide. Yes, I'm missing a slide. The adherence rates for these members were really good too. We had kind of four different peripherals that we were working with: glucometers, blood pressure cuffs, pulse ox, and weight. I had a little graph here, the adherence by type, but they were all over 88%. We had on the weight, it was 92%, and that was the highest we got. So we got people to adhere to their plan. The other slide there we go, we should have is Nurture Health, which is a subsidiary of Centene. Centene, a large managed Medicaid plan, did a study, year-long study, 400 members, all dual eligibles, with a number of conditions, really good results. 53% lower heart rate admissions, 58% all-cause readmissions, and so this stuff works. And we've seen time and time again that we can significantly improve some of the readmission issues. Thanks.
Next up, we're going to invite an old friend, Alan Portella, up from Airstrip Technologies. I have to admit, first time we saw Airstrip, we liked it so much we bought part of the company. So this company is one that's grown very, very fast under Alan's leadership. He's taken his vast experience in health IT and information technologies and really put an interesting strategy in place to grow this company. So, Alan?
Thank you very much. So I'm an old friend, but I'm not that old. So let me just, I assume, perfect. Sorry, I didn't have my glasses and I couldn't see. So first of all, I tell you a little bit what we do. We mobilize medical devices throughout the continuum of care: fetal monitors, patient monitors, EKGs. Today we cover about 700,000 babies out of every 4 million babies that are born every year. We also cover a number of hospitals on EKGs, following a patient from the ambulance, inpatient stay, and also now following those patients at home. And we recently acquired the IP for a mobile EMR extender. So now we can do the same thing with any EMR that is behind the scenes. So we can access data from Epic. Eventually, we're writing the adapters, Cerner, Meditech. That's the direction that we're taking. Now, mobilizing the two, I see a smile when I mention Mobilize and Epic. So if you look at what we're trying to do is mobilize the most important clinical data sources, and we started with medical devices and now with EMRs, and we're having a lot of success there. The first thing I want to do is I want to talk about the problem. The problem is that we're moving, which is a good thing, we're moving into a patient-centric approach, but we're adding 38 million patients to the system and we don't have enough doctors. So the reality is going to be a mess. So many of us that were all excited about healthcare, we all have to collaborate a lot because most likely the patients are going to suffer a lot. The 38 million patients that are coming to the system to avoid people without insurance going to the emergency department, they're going to have to wait 7 months to get an appointment with the primary care doctor, so they're going to end up at the ED. The hospitals are going to get paid for that visit, but then they're going to say, follow up with your primary care doctor, and it's going to take another 7 months. They're going to come back to the ED, and now they're not going to be reimbursed, and they're going to be penalized. So it's really a difficult situation. And in the past, we all thought that the EMR vendors were going to help us. We rely on the EMR vendors because we spend a lot of money bringing EMR vendors. But what happens today is we're starting to see consolidation of health organizations. Hospitals are buying more hospitals, are buying physician groups to attract patient population about management of chronic diseases. So what happens is that as a hospital, if I'm spending a lot of money buying more hospitals, I'm not going to have money to all of a sudden standardize everything on Epic, Cerner, McKesson. So now you're going to see multiple facilities with multiple EMRs behind the scenes with multiple medical devices. So the reality is if we don't bring mobility to be able to commoditize all those data sources and mobilize them and bring that data to the physicians, we're going to be in a crisis. So in any case, if we look at what are the challenges that we're facing, we already talked about caregiver shortage. We have an issue with specialists that are not enough, cardiologists, endocrinologists, are not enough to really take care of that patient population. And the primary care doctors are really decreasing. So obviously we need to start looking at virtualization of those doctors. They became mobile professionals. They don't practice in one location. Now they practice throughout multiple facilities. So they became virtual. So also, if we're looking at the management of chronic diseases, what we need to do as vendors of technology is to really start looking at each service line and start looking at what are the use cases. When we were talking earlier about the physician being at the center of all this, and we were talking about making an impact, bringing transformation, the reality is transformation is just bringing technology as an enabler, but really looking at people and process and aligning people and process with technology. So there is a requirement to go beyond the four walls of the hospital. And what happens is everybody's asking, how did you manage to get Airstrip to be that company that is making mobile technology a must-have versus a nice-to-have? And the reality is that's what we're doing. We took CHF and we went from the ambulance all the way to home, and now we're looking at other diseases. But we're really doing everything, becoming the silent partner to the patients, but we're providing all the data that the physicians need to be able to make the right decisions, but also to be able to communicate with the rest of their team. So as we move into a patient-centric model, we're not looking at the four walls of the hospital, and this is what it becomes. We have about 160 million patients that are with chronic diseases in the U.S., 70 to 75% of the population. And now you have to look at emergency departments, clinics, skilled nursing facilities. So now you really have to connect to multiple systems. Again, the EMR vendor is not going to be able to provide you all that information. You have to really connect with multiple systems. So the way we do it, we know that this is the way things look today. So you have Epic, Cerner, McKesson, Philips, GE, new companies like Sotera, a really cool one, NextGen, Meditech. So the reality is to follow that patient throughout the continuum, and you see a lot of HIEs out there. It's becoming very challenging, and we need to make sure that as hospitals are expanding and buying physicians shouldn't suffer through this pain. So what we do at Airstrip, it looks like we practice this, but we understand what the environments are, and we understand what the strategic initiatives are. We need to cut costs. We need to create new revenue models for reimbursement. We need to provide patient engagement. And of course, all this is all around outcomes improvement. So again, we put the physician at the center of this. And we know that we have to virtualize them. We have to mobilize those physicians. And we need to make sure that they can communicate with the rest of the care coordination team. In our view, EMRs in the future are just going to be operating systems like you have on your PC, and it's a foundation, but you're going to benefit on the workflow from the applications and the technology that you put on top of the EMRs. So basically, in the next 5 years, you're going to see physicians accessing all data and interacting through the EMRs through mobile devices, and then EMRs are going to be limited to the point of care by nurses, ancillary people, respiratory therapists, etc. So what we do is we recognize that we needed to mobilize, again, medical devices and EMRs. We put it all into one mobile platform. And that platform that we bring to the customers actually brings adapters to the EMRs. It brings devices, drivers for the medical devices. It brings secure platforms. As you move outside of the four walls of the hospital, you better start thinking about security, because security, as the standards that exist, is not enough. So, of course, the next thing that we're looking is analytics. We need to be able to study what we are bringing to the table. How many STEMIs am I shortening the time to intervention? How many people are coming with myocardial infarctions? What is that I'm doing by quickly intervening, and what happens on length of stay, et cetera, et cetera. So the reality, what we are trying to do again is really aligning technology with people and processes, but we really have to look at use cases for each of the high-value service lines of the healthcare organizations. And again, eventually engage with the consumers. Again, we believe that mobile technology is no longer just a nice to have. It is the only solution to really disrupt innovation moving forward. And thank you, Don, for having us.
Our next speaker has become a new friend of mine. He joined Qualcomm and Qualcomm Life here not back too long ago. He came to us from GE Healthcare, where he was CTO of GE Healthcare's technology services business, and GE's loss was Qualcomm's gain. So, Eamon.
Thanks, my new friends, actually. I just want to do a sample test here. How many of you have a parent or a grandparent that you wished they have a mobile phone so you can actually call them just to see how well they're doing? Just raise of hand. That's pretty good. Yeah. Yeah, I had a 99-year-old actually father-in-law that we bought one of those cameras to watch him. He was actually living independently, and it was pretty obvious to me the value of being able to care for someone at his home and or her home. And so when we talk about the home, we had to think about the fact that these are the grandparents, the parents who actually are not very tech savvy. Hence, we have to really make the data flow and extracting data that actually enable us to feel good about how they're doing a very easy thing to do. We do not expect them to be pairing, to a mobile phone or to anything really, including turning on a laptop. And so for that reason, if you can go to the next slide, please. Oh, that's right. I'm not as tech savvy, as you can see. For that reason, actually, Qualcomm Life was created. It's really about mobilizing healthcare. It's really thinking about those parents and grandparents that we do have, and by creating an ecosystem that does not assume, people are tech savvy, that enables the data seamless flow from the home or from wherever you are at any time, at anywhere, so that in fact you can access great services like what you just heard about from the team here, as well as you can access the data to do all kind of applications and enable new business models. So it has to be scalable, as an ecosystem, has to be scalable, It has to be open. It has to be very easy to use and to get into, as well as to access. So you can, in fact, create a lot of new business models that enables, better healthcare from wherever you are. And that's really what we had, the intention of what we did was the TUNET. The TUNET platform, when we launched it now a year ago in this place, before my days, it's really built around that. It's totally built around enabling access, ease of access to the data from your home, from any sensor. We're very much device agnostic, and we know for a fact that, when you're diabetic, you just don't end up with one device, so you're not going to be locked into, say, the device that manufacturer A gives you. It's actually, you're going to have to be using a blood pressure monitor as well as potentially a glucometer from device manufacturer B, and another thing, a weight scale from device manufacturer C. And the problem we have today is, well, unfortunately, you may have to log all these things by hand, and you have to go visit your parent or grandparent to be able to do that. Well, we really, literally, this is exactly how we built the TUNET cloud platform, which enables us through the TUNET gateway to pretty much plug and play, get the data from any device, regardless of who is the manufacturer, into the cloud, and enable anybody to access the cloud. Of course, we meet, by the way, we are an MDDS, class 1 device for FDA certified, both at the device side, our TUNET hub, as well as our TUNET cloud. And we also enable a lot of APIs from either the consumer side or the device manufacturer side to enable innovation around the data we collect. So now, we pretty much, our main intention of this is to solve the whole issue of, the total segregation of device data coming into the home or whatever you're using, and actually being able to access the data and create innovation, whether through analytics or through all sorts of applications that it will enable. So as you can see, in 1 year since we launched, we have now over 125, I think we're now close to almost 180 partners. This again shows how easy it is to become part of the ecosystem. All those 180 partners are part of our ecosystem. They tap into the ecosystem depending on their business model. And we have a lot of device manufacturers, in fact, that beam the data directly through the TUNET hub. So we think around, again, this is the TUNET hub. In case you have not seen one, please stop by tomorrow morning. And if you think of different disease types, so whether you are talking about diabetic people who will have all sorts of devices that they need to have, and these are the type of data that we collect seamlessly. And I can tell you we had some real nice feedback from some of the patients, a blind patient who actually used to log her own, glucometer readings and used the TUNET and basically, said it was so easy. Thank you. I mean, that by itself told us we're going in the right direction. And then after that is, of course, the TUNET platform. Will be enabling in a latent development here analytics, so that actually, when VRI wants to run their own algorithms, or Airstrip or any of our partners, they actually find a way to tap into, again, an analytics engine that enables them to run their algorithms. And of course, because we are FDA, we are HIPAA compliant, we give all the security basically that in fact we have inherited from our Qualcomm heritage, who is a leader in the M2M, as you all know, field, which we leverage as we basically also deal with all the financial data transaction. We deal with about 120 million messages per day in Qualcomm, and this is the same platform that's highly secure that we're leveraging for our Qualcomm Life and the TUNET platform offering. That's it. Thank you so much.
My final, and maybe our best speaker, is somebody who's probably been in the space of mobile health as long as I have been, and probably one of the most experienced and recognized folks, and actually the founder and host of one of the best conferences in the space, Connected Health. So Joe, please welcome Joe Kevadar.
Gosh darn, no pressure, huh? So this is Carolyn Thornton. She was one of the first patients at Partners that when we started doing remote heart failure monitoring 10 years ago in collaboration with our home care group. We started that journey and we thought we had this wonderful idea that if we equip patients like Carolyn with equipment similar to what you see pictured here, it's gone through a couple of iterations over the years, but not so different, that we would be providing doctors and nurses with a rich stream of data on which they could make decisions more rapidly about care of patients like hers. And when that turned out to be true, the real lesson learned and the most exciting thing that we've learned, and I feel like I've learned in the last 10 years, is how these patients start to manage themselves. Same data, same story, but when they take on their own care, they realize the relationship between diet, salt, fluid, shortness of breath, wonderful things start to happen. So we immediately, as we learn that, start to pull it apart. What's going on here? How do we fall into this realization that we actually can make patients their own doctor some of the time? And it really comes into three sort of design principles that are shown here. The first is this idea of feedback loops. We all crave them. Think about how different the world would be if hypertension and diabetes were like spraining your ankle. Right? You know the pain when you have an orthopedic injury, but these other things sneak up on you when you're not looking. So feedback loops help us provide that numeric value to train you to think about your health in the context of a number. It's really powerful. And then we have this idea that they can get anything like that can get tired on you. You can decay that sort of newness of looking at the feedback loop. So we add this motivational tool set, and that's something we're working on constantly. How do I learn what motivates you compared to me, compared to someone else, and tune the system so that we're giving you the most motivational messages that are specific to you. We're working on that. We're working on automating that and taking that burden off of clinicians, although today, and the third piece there on the slide, is we often use clinicians for that. Nurses, sometimes pharmacists, occasionally diabetic educators, occasionally physicians, to be the what we call sentinel effect. Gee whiz, and very similar to some of my co-presenters here, we noticed that you hadn't uploaded your vital signs, or we noticed that your weight was up. How can we deal with that? And that leads to the improvement in patient adherence that was spoke about earlier. So feedback loops, motivators, and then clinician involvement when needed. Those are really the three design components. Just a couple of words about some of the programs. So I don't need to spend much time on heart failure. We've already addressed that, but we have very similar kinds of an approach to what's been talked about, BRI and so forth. And it does result in lower readmission rates, 50% in our case. And it's really about this idea that we're keeping people healthy in the home. We're catching them before they get sick enough to come in the hospital, either because they're managing themselves better or we're reaching out into their home before they get too sick. Works really well, and it's very consistent in our environment. And this particular program is now in the path for all of our high-risk patients and partners as we move into the era of accountable care. Hypertension is another one we've gone after. Same kind of thing, although what's different here is that patients view their data in a browser. We use a home hub. We're actually in cahoots with these guys at Qualcomm Life to move to their device as soon as it's market ready and as soon as we can build the software around it. So we're very looking forward to that because it's so universally adaptable to all of our work. And then, of course, diabetes as well. So we've done them all. We've had great clinical outcomes with all of them. And we feel really solid about this approach now to putting patients in charge of their own health, giving them the feedback loops, the motivators, and again, clinician involvement where necessary to move this whole idea of connected health as a care model forward. And to wrap it all up, as I alluded to, we now have the reimbursement model to make it work because we're going at risk in Massachusetts with virtually all of our payers. We also do quite a bit with text messaging. That's sort of our mobile thing. When we looked at patient smartphone adoption in our market a couple years ago, it was about 10%. So we said we have to build things that most patients can use, not just 10%. So we really didn't go the smartphone route at first. We went towards texting. That's turned out to be a great digital divide conqueror for us. Everyone has a phone. Most of our underserved patients would rather text than use the internet. And we've built a number of programs around texting. Some of them are listed here, and for sake of time, if you have questions about that, maybe we can deal with that in the Q&A. But it's really a way for us to message our patients in the moment. I think that's the take-home about texting for us, is that if I know you need a health message delivered to you in a motivational way, I can get to you on your mobile phone. I know you'll pick it up. I know you'll read it. And as long as I keep changing that content, making it interesting, you'll keep picking it up and reading it, and you'll get these bite-sized chunks of motivation and education, and we find it very, very helpful across a number of conditions. So that's a very quick overview of work at the Center for Connected Health. These are my contact details, and again, if you want to reach me, this is how. I know we're also going to have a little bit of a Q&A now, and I look forward to that. Thanks very much.
Before I open up to the audience, I just have a couple of questions I'm going to pose and ask a couple of you to address. And first question I want to address to Andy and to Joe. And what I want to talk about is the mechanics of prescribing an app. And I'm going to define an app as any combination of software, devices, and maybe even a drug. So what needs to be done, and what have you done in order to get the components into the patient's hands in a timely, functional way, when in fact we don't really have the store that you normally go to where you get software, drugs, and devices all in one place?
Sure. I'll be happy to start, and I'll say a couple things about that. One is that as we move more and more to this model of care, part of the prescription process is making it the standard of care and making programs opt out rather than opt in. So our heart failure program now is opt out. We have developed a number of software tools to define patients that are at risk for readmission, and we're going to put them on this program. We will give their doctor a couple days notice. If the doctor thinks it's a really bad idea, they can come forward and tell us not to do it, and we won't, of course. But we're not asking them to prescribe anything. We're moving it into the standard of care. Once we do that, depending on the program, unfortunately, for that heart failure program, we actually send someone out to the home to make sure the equipment works. Of course, to scale it, we have to move beyond that. One of the reasons we're looking forward to the TuneNet Hub is we think we can drop ship stuff then and just have it kind of come out of the box and work. But that's the mechanics of that. And then we collect stuff after. In the current environment, again, we send someone to the home to collect stuff, then we re-sterilize it and repackage it and move it on to another patient.
Yeah, no, I think that's right. The point I would add to that is just the criteria in which clinicians use to identify people who should be on the program. So if you're thinking about a hospital readmission program, You've got, let's say, 100 people come out of the hospital, you put devices in all 100, but only 20 of them are going to come back without telemonitoring. You want 10 of them to come out, or you want to reduce that by 10 by 50%, but what happens with the economics if instead of putting it in 100 homes, I can put it in 30 or 40 or 50 homes and have better criteria around that, so your ROI is a heck of a lot better for a hospital or some other healthcare organization to put these things in the home. For heart failure, it makes sense to have these devices. For some of the other diseases or conditions, I agree with Dr. Velar. It just may not make sense to have these devices, and so if you can really focus in on the patients or the members who need this, that's really, really key.
Great. Alan, next question is for you. There is a lot of obvious benefit putting the information from the PACS systems, the medical imaging systems, the electronic health record systems, and actually directly from the medical devices in the hospital in the physician's pocket and in their hands. That's pretty obvious. It's obvious that clinical decision-making can be better when they're looking at the same information the nurse is looking at when the call is made. But could you talk to how convenience weighs into the equation for both the purchasing decision as well as the user enjoyment of what you actually offer, and how important convenience is in that equation?
Well, so thank you. So if we look at, as I mentioned before, hospitals consolidating and starting to look at buying physicians' offices to be able to attract the patient population, you have to realize that the physician groups in different regions, they could go with any of the healthcare organizations in those regions. So what happens is now healthcare organizations are looking at mobility as a way to improve the quality of life for those physicians as they are practicing throughout multiple facilities. So it's becoming a key component now to attract physicians to the organization, basically saying you can go to any other organization, but we have multiple hospitals and centers in our region, but the way you're going to manage the population health is going to be through mobile devices, and you're going to be able to look at all the data sources that you need in one place that you don't have to go to. The data is going to come to you. So definitely that's becoming huge, and that is also becoming very attractive as those healthcare organizations are advertising in the community that now they're providing mobile technology to their physicians to be able to track them throughout the continuum of care.
John, I'm going to call on you here. You've chosen a particular kind of sensor, and there's lots of sensors that are in the body, on the body, around the body, environmental sensors. You've chosen one that we label smart Band-Aids. So wireless devices that are actually wearable, disposable in a way. Can you tell me why that particular kind of sensor was attractive to you, and what value proposition the smart Band-Aid means to you in your services model?
Sure. So we were fortunate to be a part of the large medical institution in Minnesota that had spent a sizable number of years with the core research and with a secondary contributor in a chip manufacturer, a large chip manufacturer. And when you look at the advancement and the focus that the institution had on the clinical protocol and what type of power was required for exposing that protocol in a clinical way, we needed the power. So the first thing was the circuitry that was in the actual device. It's a sizable 32-bit processor with very focused battery consumption parameters and able to run part of the clinical protocol actually on the device. So it started with that. But when we backed up then and said, no, let's go back to the patient, the paradigm of the patient. What's ergonomically usable? What type of clinical problems are we trying to solve for that patient? We had to spend a lot of time at the industrial design part, the human factor part of it. And there's clothing, there's Band-Aids that are not adhesive. You start looking at the life patterns of an individual that may have a chronic disease or atrial fib. You got to look at all the parameters around wearability, not just the function and the clinical, but wearability to that patient. And so we found that this works well for us at this juncture. The clinical trials are proving that it's easy to use. We actually pair the device with a smartphone, so the interface is extremely simple to use. We, of course, are experimenting with other types of devices. There's some clothing that's looking very interesting based on certain surgical conditions. I said earlier about the pre and post, the use of this technology of pre-procedure, during procedure, and post-procedure. And I do believe that the sensors used will vary based on those states in a patient's life. Pre-procedure, of course, you may go to a primary care physician. He or she wants to set a baseline on you, whether it be cardiac. Maybe it's something they hold to their chest for an hour or so. When you're at post-procedure, depending on the condition again, just finished actual heart surgery where the chest is actually opened. It's a delicate area. Well, the cloth is a little better. And then when you're home and moving about and trying to get back on your feet, the adhesive works very well. So I believe, Don, it is going to change. We started with the adhesive. It's very convenient. And again, back to the circuitry and the power to be able to split the medical protocol across the different computing platforms.
So we have up here some of the larger providers of mobile health solutions with a lot of experience. So I'm inviting any of you to approach the microphones and ask questions. This is a pretty unique group of folks with a lot of experience under their belts.
We've heard of reductions in readmits of 50%, 58%. What's the cost, telehealth cost, per avoided readmit?
In our case, it's, and I stress that what our effort these days is to make it more efficient, but currently it's about $250 per patient per month, all in. Oh, well, the readmission's about $14,000 worth of savings, so, yeah. Per avoided readmit, we have not done that calculation. We could, I just haven't done it that way.
Yeah, but I'd say we haven't looked at it that way either. I think, when I'm a business owner, I make decisions based upon return on my investment. So, the way that I look at it, and health plans and hospitals are looking at it is, what is my ROI? What am I saving? And what we found is if you don't get a 3 or 4 to 1 ROI, you're not going to get in that top priority list of a health plan or a hospital. So, yeah, I'm just saying I have not calculated that way. I'm doing just a pure ROI calculation, which resonates with me, but
At a population level.
At a population, right?
I'm not very good at math, so I'm not doing well.
If I can make a comment on that, of course, the position at Airstrip is that we like to look at the continuum, not just what happens when the patient goes home. So the way we look at everything is, if I get a patient that is coming in the ambulance with a complete blockage of the artery with a STEMI, and I can reduce the event to balloon time, instead of 90 minutes, I do 35 minutes, now I have a healthier heart for that patient. What we saw is that then there was a reduction of false activation of cath labs, which is significant in any hospital. And then you look at the ICU length of stay and you see a reduction of 0.85 days. It increases the bed capacity, patients coming in from the emergency department. Then we looked at the step-down area, and then we were able to look also more reimbursements on having cardiologists signing off on the patients and looking at that. So then if you look overall at the savings and the new revenues that we can generate from the ambulance all the way until they get discharged, then already there is enough of a justification to be able to pay to bring sensors into the home for those patients to be monitored that are high risk. But if you look at that number that you were talking about, the average in the country they're talking about is $750,000 that hospitals, for example in CHF, are going to lose every year for readmissions, 30-day readmission rate. So if you look at 50%, it would be half of that.
So let me just emphasize here, the topic here was going home from the hospital, but Alan actually has applied his technology to sort and find the most appropriate high-revenue patients, I'll emphasize that, going to the most appropriate high cath lab centers with an ROI that shortens their length of stay. So sourcing the appropriate patients, getting them to the right center, and then reducing the cost once you've gotten them there. Go ahead.
In respect to scaling these solutions, are you finding any challenges with discoverability on the part of both patients and providers of the solutions that you offer?
I'm not sure, Conrad. Can you tell us what you mean by discoverability?
One of the challenges that I've been observing in working with primary care providers at the front lines on new technology is the ability to determine what apps are most appropriate for their practice. And then when you look at the end user as the patients even have a more challenging environment to be able to figure out what really is right to bring into their homes. So we come back to the issue of prescribing the apps, and how is that working? That's right now that's a kind of mystery space that I'm not clear on. How is that connection happening between the provider, the patient, and the right technology for it?
So our organization may be unusual, if not unique, in the sense that we have 50 people that are in our center that are largely, a lot of their responsibility is helping with that problem. So we tee things up, we test them out in our own environment, et cetera, to get them to their point where they're scalable. I'm not sure how others do it, but we have a whole team of people who that's their job, is to make sure that we're doing the right thing, choosing the right stuff for the clinicians and the patients.
I think the holy grail here is actually scalability, which is a little bit of top-down direction. Alan, maybe you just comment on what groups like HCA have done to actually drive the mobile technology into their system from a top-down perspective.
Yes. So clearly, I always talk about that the visionaries of today are no longer the academic medical centers, but the large healthcare organizations that they have to figure out how to manage population health throughout multiple states. So if I use three examples that are in the same category, will be HCA, Dignity Healthcare, Vanguard, places that are expanding significantly. They already recognize that they need to bring mobility in order to be able to bring the data to their doctors. So what the biggest challenge for us on scaling was always figuring out how we can study each use case around high-value service lines. So how do we manage CHF? What data do the primary care doctors want? How about the case managers? What do they need to communicate with the cardiologists, and what data needs to go back to the hospital? So you really need to look at every use case and not just bring the application and expect that they're going to use it, because the reality is that they're going to use it for 30 days, and it's like every app that you download on your phone, then you just don't use it anymore. So you really need to bring a lot of value. Moving forward, now that everybody's cutting costs, unless you bring value, people are not going to buy your technology, and you need to measure that on a daily basis.
So Alan, and maybe Joe, you'd weigh in here on, it strikes me that you're not having these conversations so much at the individual doctor level, but you're actually having it in the C-suite of the actual healthcare system, making decisions for deployment. And Joe, maybe you'd weigh in as well.
And the beautiful thing is that at the beginning that was the case. We were talking just at the C-suite, but now the C-suite, which is the beautiful thing, I have been in healthcare for 20 years. It's the first time that the C-suite tells me, you go and you talk to the physician champions, and you figure out what their pain points are, and then you make sure you bring them to me with their use cases, and let's figure out how we can help them. So this is the first time that we're really looking at the real needs of the physicians. I have been in healthcare, and this is the first time that people are paying attention to the physicians.
I would say, too, one of the things that Joe and I mentioned earlier is you go out to this exhibit hall and you see a bunch of the devices, a bunch of apps. I think what we do is take a very consultative approach to this, where you can match skill sets and connectivity to the right prescription, meaning that I kind of alluded to it earlier. It may not make sense if somebody just has hypertension to put $1,000 or $1,500 worth of devices in their home, because you're not going to get an ROI on that. you might need an app or an IVR solution or a text solution. And so all the health plans that we work with, they take us as the consultant, the one who makes some of those decisions. We have multiple units when we go into the home, so if you can't get connectivity with AT&T, maybe you get connectivity with Verizon. They are requiring us to make sure that that person can use whatever device we put in the home, whether it's a device, a cell phone device, or a TuneNet hub. So we kind of take that on ourselves. The plans that have failed at this and the hospitals that have failed at this say, I'm going to pick this, and don't let us deviate off that at all, because that's really, really difficult to scale. We go into these RFP processes where you've got 30 people from this health plan who are evaluating a bunch of different devices, and they pick a device, and that works for maybe 50% of the population, and they say, well, why did the other 50% sign up? Well, because they don't have broadband, or they're 95 years old with Parkinson's, and they can't use a touch screen. And so you kind of have to think about these things prior to just picking a solution and going with it. You need a portfolio of integrated solutions, and that's really the only way that you can do it in a scalable fashion.
Go ahead.
Hello, everybody. Ravi Kubraj from Microbionic. I kind of have a personal observation and then I have a follow-up question. One is, back to what you were saying about quantifying the procedures that were not done or avoided. I would say that math is non-trivial. Always changing goals for that. And if you do get that answer, I'd love to get the formula. The second one is, as kind of a co-founder of the emerging mobile monitoring company, what would you recommend as business models that will emerge in terms of payment, in terms of reimbursement, in terms of working with hospitals? Thank you.
Well, first of all, I wanted to say, if you're getting into the business of remote monitoring, you better partner with us. Don't start it, I don't want more competitors. But definitely, if the way we approach it right now on the reimbursement side, if you look at transformation is really bringing information, interoperability, and incentives. And if you look at the incentive side, is you have to start looking at the federal programs like Meaningful Use. What is the value that I can bring with mobility that maybe if I drive more physician adoption, the more I use the systems and interact with the EMRs and other systems, maybe I qualify more for meaningful use. So you have to look at incentives in all areas, not just reimbursement. And of course, every time you introduce technology, everybody says, so who's going to pay for this? And the reality, I go back to my comment before, it's not just about the potential share savings that you have over the next 2 years by preventing readmissions, but it's really looking at every step throughout the continuum and figuring out what impact do I bring to the table, what savings do I bring to that provider, what potential new revenues can I generate, and then what is that they can get on additional incentives when those patients are monitored at home. And that's what we do. And when we go into any healthcare organization, basically we say, this is what we bring you, this is what we charge you. But the idea for us is to really work on a partnership. That's why we use a SaaS model. On a SaaS model, it's not that they pay you a bunch of money up front. You have to bring value at every step of the way, because otherwise they kill the process.
So two things. On the previous comment for just a moment, as an academic medical center, we're sorry to have to give up the mantle of visionary. But we're going to try to earn it back, so don't go away. Don't give up on us just yet. Don't give up on us just yet. To this point, I would say one thing, which is the strategy of trying to get something with a code that CMS is going to pay for is really a dead one. So I really strongly wouldn't recommend that. Just to frame what my colleague said in a different way is you're trying to convince an organization like mine to buy your technology as a business expense to achieve some sort of efficiency in operations. And that's the way you have to start thinking. And that's, I'm sure, why Airstrip is successful, because they've adopted that kind of a strategy.
Let me add one more thing. since you're starting, don't reinvent technologies, plug into an ecosystem like what we're doing, because that actually will get you to market fairly quickly and enable actually a lot of ideas that you can benefit from. So.
Let me emphasize on that. So there's a real estate race going on that not everybody in the healthcare industry recognizes. But whether it's the consumer that's going to use an app from a retail pharmacy, they're not going to have a retail pharmacy app on their phone from every retail pharmacy. The one that gets them the app that actually satisfies their needs, gets them their refills, they own that customer. There's not going to be room for another app. Same thing for the physician. Airstrip's well down the path here of kind of owning the real estate in the physician's pocket for accessing the data out of the healthcare systems. They really are a partner to potentially partner with from other monitoring sources, and they're actually doing that because they are starting to own a real estate position. Physicians are not going to have multiple systems in their pocket. They're not going to get used to it. They're going to get used to one and want to stick with one. So I think this notion. One of the conversations we often have with companies who basically come to us, and these are often Fortune 500 companies, and said, well, we're not really sure what we want to do yet. We're going to study this a little bit more. And what they wake up one day is realizing they lost the real estate race. Well, thank you. I want you all to thank my panelists, and I'm sure we'll all stick around for a few questions. Thank you.